This lecture will briefly review the nervous system assessment. We will be spending time in class going through all of the various steps of an in-depth assessment of the nervous system. First, we're going to take a look at the subjective data collection or the history-taking portion of the assessment. You want to be sure to consider 3 points when taking a history of a patient with neurological problems. One of the first things you want to think about is to avoid suggesting symptoms or asking leading questions. One of the second things you want to be sure to gather important details on the mode of the onset of the illness and the course of the illness that has taken place to date. These are very important aspects in your history taking of a neurological disorder. Often the nature of a neurological disease can be determined by these facts alone, as we will discuss it when we move through the various disorders. We want to make sure that we obtain data related to specific characteristics and the progression of the symptoms. Another important factor to consider here is that birth injuries can lead to long-term permanent neurological deficits. So we are going to be gathering, in some cases, a very long, lengthy history of neurological problems. The third point to consider when collecting subjective data in a neurological assessment is that the patient may not always be considered a reliable historian. If that's the case, it is okay to confirm or obtain the history from support persons. So looking at some other aspects here with our subjective data collection, we're going to touch on medications. We need to inquire about the use of any types of sedatives, opioids, mood-elevating drugs. We need to think about any type of drug that has potential neurological side effects. As far as surgeries, of course, we'd want to know about any surgery involving a part of the nervous system, such as the head, the spine, or any of the sensory organs. In regards to growth and development, you do want to determine whether the nervous system dysfunction was present at an early age or if it has been more of a recent occurrence. We specifically want to inquire about any major developmental tasks, such as the age of walking and talking, if this has been a dysfunction that was present for several years. So we look over on the right-hand side through the column of different aspects of this subjective data collection. And so these are some questions that we're going to want to ask. In terms of the patient's health management, we want to ask about the use of alcohol or recreational drugs, what kind of safety practices in a car or on a bicycle or on a motorcycle. Here we're thinking about the use of seatbelts, the use of helmets, protective equipment. If they have a history of hypertension, are they controlling it? We're asking these questions because, for example, uncontrolled hypertension does increase the risks for a stroke. Not following proper safety practices, such as not using seatbelts, not wearing helmets on bicycles and motorcycles, increases the risks for head injuries. So we're looking for any of those practices that may be increasing their risk for a neurological injury or disorder. We also would want to know, obviously, if they've ever been hospitalized for a neurological problem. Onto the nutritional aspect here, we're needing to know if they're able to feed themselves, if they need any assistance with that. Do they have any chewing or swallowing difficulties, any problems with paresthesia in the face or paralysis, any problems with muscle coordination? All of that can contribute to nutritional problems. As far as elimination, we need to know about any incontinence of the bowel or bladder, and we would want to inquire about the timeline for incontinence if they did report that. We're certainly looking for any new or sudden onset of these problems. Also, in addition to not just incontinence, but do they have any problems with hesitancy, urgency, or retention? When we look at activity and exercise, now we're going to ask about if they're having any problems with their usual activities or exercise as a result of the neurological problem. So is this new neurological problem possibly getting in the way of their ability to just conduct daily activities? Any weakness or lack of coordination that they've noticed? And are they able to perform personal hygiene independently, or do they need assistance with that? In the last bullet there, we're going to inquire about cognitive and perceptual issues. Here, you just need to ask the patient if they have noticed any problems or if they've noticed any recent changes in their memory. We would also want to know, as far as perception, any experience with dizziness. Are they experiencing any heat or cold sensitivities, any numbness or tingling anywhere in their body? Do they have any type of chronic pain? And if so, they'd want to tell you more about that. Any difficulty with verbal or written communication? And have they noticed any changes in their vision or hearing? Obviously, if there was a yes to any of those questions, we would need to gather additional information. As we move on to the objective data collection or our physical examination portion, here we're going to look at 6 different components of the physical assessment of the neurological system. The physical exam includes a mental status examination, the assessment of the cranial nerve function, the assessment of the patient's motor function and sensory function, assessment of their reflexes, and then assessment of their coordination and balance. So as we move through the next few slides, we're going to look at each of these in detail. We're going to talk about them just a little bit, but as I mentioned, we're going to actually spend time in class going through the motions of each of these 6 parts of the physical examination. And you're also going to have handouts that are included on Canvas that provide even more detailed information about how to conduct every aspect of these 6 components. So the first component of the physical examination for the neuro assessment is looking at the patient's mental status. Assessment of the mental status gives us a general impression on how the patient is functioning. Much of the mental status examination can be assessed during our interactions with the patient. There are 2 common tools that can be used to do a mental status examination that can be utilized as part of it. They're not the entire mental status exam, but they are a component of a mental status examination. Those are known as the mini mental exam and what we call the slums exam. These are the 2 most common tools used to get a quick look at a patient's overall mental status. We are going to, in our laboratory stations, be using the slums tool. So you'll get a better idea of what that looks like, and you'll get a copy of that as well. The components of the mental status examination are 1, looking at the patient's general appearance and behavior, including their level of consciousness, their motor activity, noting their body posture, their dress, their hygiene, even their facial expression and their speech patterns. When it comes to their level of consciousness, we need to know about their person, place, and time. Altered level of consciousness has several different terminologies that can be used to describe that. Somnolence is one, which is a state of unnatural drowsiness. Lethargy is another term that can be used to describe an altered level of consciousness. This refers to someone who is excessively drowsy. Stupor is yet another term that we could use, which is defined as someone with a decreased response or lack of movement. We can even go on and talk and use terms semi-coma or coma. These are all going to be subjective terms, and so it is much more accurate if we can find a way to describe the patient's level of responsiveness in a way that gives everyone, all healthcare professionals working with this patient, an understanding of where they're at. And one of the best ways to do that is the Glasgow Coma Scale. And this is the scale that you have on the slide for you here. I do not need you to know the individual scoring of each of the categories. However, the things that you do need to gather from the Glasgow Coma Scale is 1, this is a neurological scale which aims for us to give us a reliable and objective way of recording the conscious state of a person. So like I'm trying to explain is that this is better. This objectifies your opinion or your perception of your patient's level of consciousness versus the terminology that I used earlier, which is very subjective. So this also provides us a great baseline for a patient's level of consciousness. And when we repeat the Glasgow Coma Scale from one neuro check to the next or from one shift to the next, it provides a tool for us to continue assessing the patient to see what changes are made. So what you need to know with the Glasgow Coma Scale, first of all, is the lowest score a person can get is a 3. Obviously, if you were to look at this scale here in front of you on the screen, you would see that if someone would get a 1 for no eye opening, They could get a 1 for making no sound under verbal, and they could get a 1 for no movement under motor. So a individual who was deceased could technically get a score of a 3. So that's the lowest we can get. And then you also need to know that the highest possible score on this scale is a 15. So you can see there, the highest you can go with the eyes is a 4 when your eyes are opening spontaneously. Verbal, the highest they can go is a 5. They're oriented and conversing normally. And the highest they can go in the motor is a 6, where they're obeying commands. Now, 13 to 15, anywhere in that range, is usually a person who is functioning normally. That's going to be the highest pretty much level of being cognitively intact and conscious. And the other thing that I need you to know is, what are the 3 categories that we're scoring people in? Like I said, I don't need you to know I don't need you to memorize what action gets you, say, a verbal score of a 2 or a motor score of 3. But I do need you to know that the scores range from 3 to 15, 3 being the worst, 15 being the best, and you do need to know the 3 categories that we're testing. We're testing the eyes, we're testing the verbal response, and we're testing the motor response. All right, let's take a look at the cranial nerve assessment. There are 12 cranial nerves. Your need to know here is you need to know the number of each cranial nerve. We assign them numbers as Roman numerals, as you can see on the slide. You need to know the name of each cranial nerve, and you also will need to know the function of each one and how that cranial nerve is tested. I've included a handout that does break that down, a little chart that makes it a little more simple to study, and that is attached to Canvas. You also have the handout that we're going to be going over in lab, and we will actually be going through the steps of testing each of these cranial nerves. So in the recorded lecture, I'm not going to go over how to test every one of them, what their functions are, and obviously all of their numbers and names are right here on the screen to review, but you're going to need to spend some time reviewing the information and making sure that you understand it. The motor and sensory function slide actually cover 3 aspects of our 6 when it comes to the neurological assessment. So 1, we have motor function, which is going to look at the patient's strength. For example, their ability to push against resistance. We're going to look at their tone as we passively move their limbs. We're going to check from left to right in both their upper and lower extremities so that we can assess for symmetry. Then if you look at the bottom of this first column, you're going to see that coordination, balance, and gait by terms of the finger to nose or heel to shin test is what's going to be included there. That is a subcomponent of motor function. However, we do treat it as its own separate assessment in that 6-piece neurological physical examination. So we will, as we move through the laboratory stations, our assessment of motor function will be done separate from our test for coordination and balance. One of the things you're going to do at the coordination and balance station is a test called the Romberg test. This is a test where we have the patient stand with their feet together and their arms at their side and close their eyes. We want to see if the patient is able to maintain the balance with their eyes open and shut, or if once their eyes are shut that they sway or begin to fall. If they do start to sway a lot or even risk falling, this is considered a positive Romberg test. One thing you have to be careful of during a Romberg test is patient safety. So you have to make sure you have somebody on the front and the back of the patient if you're going to be performing this exam. Onto the other side, here we look at sensory function. This is a separate station as well. So again, there are 3 stations kind of wrapped up into this one slide. With sensory function, we're looking at the patient's perception here as far as touch, pain, temperature, vibration sense, and position sense, what we call proprioception. We'll also be testing some cortical sensory functions. Two of them are known as graphesthesia, which is the patient's ability to feel writing on the skin, and then stereognosis, which is the ability to perceive the form and nature of an object. So graphesthesia would be done by, say, writing a number with your finger onto the patient's palm of their hand, like a number 2, and seeing if they can recognize the number that you're writing. Stereognosis is going to be having the patient close their eyes and identify something that should be easily recognized, such as money, like coins, or a paper clip in the palm of their hand. The last component of the neurological assessment that we're going to look at is the reflexes. We are going to have a station set up where you're going to test each of the following reflexes. We'll go through the biceps, triceps, brachioradialis, patellar, and Achilles tendon reflex assessment. A reflex assessment isn't something that we would necessarily do on all patients, but when we're assessing a patient with a potential or known neurological disorder, getting adequate reflex assessment in various locations is important. We've also included the reflex response grading scale here for you to look at. This isn't something that you need to memorize score for score, but understanding that obviously if we gave someone a 0 on the reflex response, that means that they have an absent reflex to that particular area. So you would need to identify which reflex it was that you weren't able to locate, versus a 2 being a normal response and a 5 being what we know as clonus, which is an abnormal response, where there is continued repeated contractions of the muscle after applying the stimulus or eliciting the reflex response. It continues to twitch and jerk after using the reflex hammer. So 0 and 5 would be our abnormal responses. A 2 is what we're looking for as a normal response with a reflex assessment. So we have a couple of slides here as we round out the nervous system assessment lecture, where we're going to look at some diagnostic testing. We'll cover some additional diagnostic tests at times with some of the different neurological disorders, and even mention some of these diagnostic tests in a little more detail. But just to give an introduction to some of the most common nervous system diagnostic tests, the first one that we will look at is the lumbar puncture. A lumbar puncture is done to obtain a cerebral spinal fluid sample for analysis. As you can see in the image, there are 2 options for positioning of the patient. We can either place them in the lateral recumbent position or in a seated position, usually bent over a bedside table with their chin to their chest. The cerebral spinal fluid analysis is important because it can provide us with information about a variety of central nervous system diseases. Normal cerebral spinal fluid should look clear, it should be colorless and odorless. There should be free of any red blood cells, and it should contain very little protein. As we go through some of the disease processes, we'll talk about how that cerebral spinal fluid analysis actually looks different with certain diseases. So the best way for us to get this, again, is through the lumbar puncture. It's important to note here that a lumbar puncture is actually contraindicated, so it should not be done in the presence of a patient with increased intracranial pressure or a patient with an infection where the site of puncture would need to take place. These are a couple of potential problems that can increase the risk for a brain herniation in a patient. So we do not want to do that if we think that the patient has indications of increased intracranial pressure or infection at the puncture site, the area where the puncture would need to take place. So some nursing considerations here is that, 1, before the procedure begins, you want to have the patient void. The best position to put them in is that side lying or lateral recumbent position. The seated position, though, may also be used depending on the patient. The patient's usually placed left or right with their head, with their neck and knees bent in full flexion up to their chest, approximating what we refer to often as a fetal position. If they are setting up, then we would want them at a bedside table with their back arched over the table and their chin to their chest, as I mentioned earlier. The patient will be informed that a sterile spinal needle will be passed between the lumbar vertebrae. The lumbar puncture is performed either in the space between L3 and L4 or between L4 and L5. This is because the spinal cord ends at L2, so they want to go low enough that they eliminate the concern of possibly puncturing the spinal cord. It's normal for the patient to feel some temporary pain radiating down one leg as the needle is inserted. The cerebrospinal fluid is withdrawn through a series of tubes and does need to be sent off immediately for analysis. After the procedure is over, nursing considerations would include to be sure to monitor the patient for a headache, the intensity of the headache, as lumbar puncture does carry a risk of a spinal headache. We would also want to monitor the patient for signs of meningeal irritation, which would be a reporting of nuchal rigidity. And last, we would want to watch for any signs or symptoms of local trauma at the puncture site, such as hematoma or pain. We're going to check for the presence of blood. They're going to apply a pressure dressing over the back, so we would monitor that dressing. And the patient's going to have instructions from the physician to usually lie flat for approximately 4 to 6 hours post-procedure. A couple of other diagnostic tests we have are the CAT scan and the MRI. Both of these have been discussed in previous classes and in previous lectures. We can use either of these to give us detail, particularly when it comes to the brain. The CAT scan can be completed both with and without contrast. Without contrast can be done in a matter of just a few minutes. So sometimes we will do a CT scan without contrast and even repeat one later on with contrast, depending on the timeline for treatment of a patient. It is a great tool for assessment of the brain because it does provide a three-dimensional representation of all of the intracranial content. So it gives a really good picture of the brain. The MRI will provide even greater detail than the CAT scan. So that is an important tool as well when it comes to diagnosing problems of the brain. The MRI takes longer to complete. So if we're dealing with a patient with any type of life-threatening neurological emergency, an MRI is not going to be our diagnostic tool of choice. Cerebral angiography is a diagnostic test that can be done if they suspect vascular lesions or tumors. They can use this. This is done, a process done very similar to a cardiac catheterization or cardiac and coronary angiography, as you would have talked about in previous classes. So they're going to insert the catheter into the femoral artery. Sometimes they'll use the brachial artery, and they will pass all the way up through the aortic arch into the base of the carotid, or even into one of the vertebral arteries, and inject some contrast media, and they're able to take pictures of the blood flow throughout the brain. This can help to look for the presence of several different types of brain defects or neurological problems such as abscesses, aneurysms. They can use it to look for hematomas, and as I mentioned before, even tumors. The last test mentioned on here is the myelogram. The myelogram is a test that involves a lumbar puncture, and instead of just removing a sample of cerebral spinal fluid, with this test, they're now going to actually inject a contrast medium into the subarachnoid space, and they would use it to detect spinal lesions or even ruptured discs or tumors. On our final slide, we're going to look at some electrographic studies that are done with the nervous system. The first test is the EEG. The EEG involves a graphic recording of the electrical activity of the brain. This is done by placing electrodes in specific areas on the scalp, as you see in the image here on the slide. The test can be done to evaluate not only for the most common things that we do is to evaluate for seizure disorders, but we can use it to also evaluate patients with brain injury, patients with sleep disorders, or even patients with cerebrovascular lesions. The EEG is a very common test to both diagnose and treat seizure disorders, and for the most part, the typical EEG lasts about 20 to 40 minutes, but when they are trying to further evaluate patients with seizure disorders, they can do prolonged EEG monitoring that can last much longer than the normal 20 to 40 minute EEG. They can do them that last several hours, and they can even do them now that last several days. Some hospitals in more urban areas have dedicated EEG patient rooms set up to where the patient can actually be continuously monitored for days at a time. An EEG is a non-invasive procedure. There's no risk of electrical shock to the patient. A few nursing considerations with this test are that the patient may be told to avoid stimulants for anywhere from 24 to 48 hours prior to the test, depending on the testing center's rules. Another rule some testing centers have is that the patient have no sleep prior to the test. This just helps the patient to be more easily rested during the procedure, to be less likely to be aroused or abnormally stimulated. So if they've been sleep deprived coming into the test, they're more likely to lay down in this dark, quiet room and go right to sleep, giving the evaluator a better reading. The next one mentioned there is the electromyography, or the EMG, which we did talk about already in the musculoskeletal system assessment. And here we include the nerve conduction studies. So nerve conduction studies can be done separate or in conjunction with an EMG. So as I was mentioning with the EMG, that test looks at the ability of the muscles to contract when stimulated by a nerve. So we simulate a nerve stimulation to the muscle to see if we get it to contract appropriately. That test can be done to look for musculoskeletal disorders, as we mentioned in the last section. However, we can also do the nerve conduction study portion in conjunction with the EMG. And here, instead of stimulating the muscle to see if it contracts, the nerve conduction looks at does the nerves send the impulses correctly to the muscles. So when both tests are done, it can help a practitioner determine if a patient is having specific symptoms of, say, poor muscle contractility or poor coordination or weakness. It can help them determine whether it is a musculoskeletal problem, meaning the muscles aren't, receiving the signals correctly, or is it a neurological problem, which is what the nerve conduction portion of the test does, to say, okay, is it a problem where the nerves aren't sending the impulses correctly? The last test mentioned there is evoked potentials. This test is a recording of electrical activity associated with nerve conduction, specifically along the sensory pathways. So this technique is useful primarily in diagnosing abnormalities of the visual or auditory systems, because it helps to reveal whether a sensory impulse, such as vision or auditory, is reaching the appropriate part of the brain. Some indications for an evoked potential study could be evaluating the consciousness of a patient. It can be used sometimes in patients with multiple sclerosis, particularly if they're having optic disorders in conjunction with their MS, and then patients with acoustic neuromas, which we'll talk about in our sensory section later on.